Good morning, everyone. Thank you, Melanie, for starting us off. Looks like we already have 28 people in attendance. I'm sure we'll have some others joining us throughout the rest of the presentation. I'll start off by giving you a very warm welcome to this month's Multidisciplinary Approaches to Ending Homelessness webinar. This month, we are focusing on senior homelessness and are truly excited. We have two very amazing speakers scheduled to talk to us about the different approaches that their teams are doing to support this very, very vulnerable population. Our continuum of care has made a commitment to work towards reducing the number of seniors who are experiencing homelessness. And with, I was going to say what a year it has been, but we're already into the new year. But as you all know, since the start of the pandemic, our county launched a large non-congregate shelter program, Project Room Key, and engaged in a 100-day challenge to end senior homelessness, setting a goal of placing 140 seniors from that program into permanent housing. And what a success that has been. And while we weren't able to reach our goal of 140 seniors during the first 100 days, this team, many of you that are on this call and the people that you go to work with every day, stayed committed to that goal and worked together to identify housing units, secure whether it was housing choice vouchers through the Section 8 program, or utilizing other rental assistance programs and moving assistance through Home Safe, our emergency solutions grant funding, and other programs. We were able to now exceed that goal, and we have placed well over 140 seniors into housing, and of course continuing to do that. I think the last numbers I saw were that we still have some seniors in Project Room Key, and we that team, along with other partners such as the Office on Aging, Adult Services, CityNet, Path of Life, all of our nonprofit agencies are continuing to provide the hand-holding support that they need to get them into housing. So it's very fitting that this month's webinar will focus on that topic. So just to remind you about the purpose of our webinars, again, this is an opportunity for you to share on best practices. They are recorded, as Melanie mentioned, so make sure if your video is on that your hair and your lighting is where you like it. All of our webinars are posted on our website. We'll make sure to include a link here in the chat box. I'll do that shortly. And if you are interested in speaking, please do reach out to us. Let us know. We are doing our part in trying to plan ahead to secure good speakers for this session, and you can email us at coc@rivco.org. We have a slide for that, but I'll go ahead and jump ahead now to the agenda for today. We did this welcome. We're first going to hear from Juana Gonzalez, who is the Social Services Supervisor at Office on Aging, and Mel Haynes, who is the Regional Manager there. Welcome. And then we'll jump into hearing from Rosalie Ramirez, Program Specialist with the DPSS In-Home Supportive Services Program. We want to encourage you to use the chat box to type in your questions as the sessions are going. Speakers, we encourage you to check out those questions as they arise, and then you can answer them as you go. But definitely, if we have time in the end, we'll make sure to read out any questions to the speakers so that those can get answered. Without further ado, and Melanie, we can jump over to the next slide. I'm going to go ahead and hand it off to both Mel and Juana. Thank you for joining us.
Hi there. Good morning, everyone. Per Tanya, is my lighting, my hair looking okay on camera?
You're looking great.
Okay. All right. Well, this is my first meeting. My name is Miley Haynes, and I am the regional manager, new regional manager over at Office on Aging, and very excited to be here again. And our supervisor over our new homeless case management program is Juana Gonzalez, who's present here. I believe our deputy director over operations, I see his name, I think he's here, Gary Robbins. So I also would like to introduce him as being a part of our agency and our presentation today. So what we wanted to do is, with a lot of excitement, and hopefully we can give a good summary overview of our new program to you all so we can collaborate and work together in our efforts. So if we go on to the next slide, we wanted to talk about our goal. Our goal and our mission for our program is really to continue the efforts from some of our community partners in supporting our seniors age 60 and over in their newly housed situation. So it's the warm handoff process in which we will, Office on Aging, continue to provide case management services and follow through on some of the services that have been linked or have yet to be linked, and really advocate for stabilizing our seniors into their new home environment and making sure that they have the consistent services over time to sustain their level of independence and security in their new home. And so part of it is, on the next slide, is working with, again, our community partners, and some of the referrals in which we can receive from these seniors is through our help link. So we have a call center, and so anyone in the community can call in and inquire about our services, and depending on the criteria, there will be linked to our case management services through that way. So there's through help link, and then we can also get referrals through our department partner through Adult Services Division, through their homeless program. And so there is that collaboration piece there, and continuing with our case management efforts and case plans. Then there is referrals through our Housing Authority program, as well as our internal program in Office on Aging through some of our other HEARTS, MSSP, caregiving programs. So there's also referrals that we can receive that way. And so what our case management program does is something that Juana Gonzalez will go ahead and cover, and I'd like to introduce her and bring her on board now. And then if you have any questions, please feel free to put them in the chat. And then we will be happy to add our contact information also, our phone numbers, in case you all have any questions or actually have a referral for us. So thank you all. And I'm going to pass it on to Juana. Thank you.
So thank you, everybody. Happy to be here and work together with all of you. So I am Juana Gonzalez with the Office on Aging, like Miley said, and we're excited to start our case management program for our recently housed seniors. So part of the case management is going to be that we're going to, we're in the process of, but we're going to have 4 social services practitioners that will be assigned cases. We'll have 2 service assistants that will also be supporting the unit. So part of what we're going to be doing is obviously conducting a very thorough biopsychosocial assessment with our clients upon receipt of the referral, and we're going to assess what their needs are. So as we all know, even though they're housed, we want to make sure that they stay housed. So we will conduct a thorough assessment to see if they need, medical, whatever it is that they're coming with needs of, then we're going to try to address that through a care plan. Our SSPs will be working very closely with them. They'll do face-to-face contacts. They'll do phone contacts, whatever it is, to engage and to build rapport with our clients so that we can ensure that they stay housed and that they're linked to whatever services they need. So part of the service plan is going to be done with goals that are worked together with the client. So we're not going to come up with the goals. We're going to work together with them so that it's mutual collaboration and buy-in, obviously, from the client. And we'll come up with objectives and goals that will address whatever their safety issues may still be, or if there's stability issues, and obviously to ensure their well-being. So how long our cases will last depends on the needs of the client. They can last anywhere from 3 months to 6 months, depending on what they need. What we're looking at before we step out and close the cases is that they're obviously stable, that there's no risk, no obvious risk of them losing their housing, and that they have external supports. So we obviously want them to be independent, but we want to make sure that they have linkages to other resources in case they do require some assistance later. So that's pretty much the bulk of case management. Could you please turn yes, thank you. So part of the case management, obviously, and what we're doing is advocacy and support to our clients. So the very first goal, obviously, is to maintain their current housing, which we talked about earlier. And what we're going to be doing with that is working closely with our clients and making sure that they're compliant with their lease agreements. A lot of time, by the time we get the referrals, they've already maybe forgotten to make their first payment or second payment because they're not used to that. So part of the advocacy that we're going to provide for them is obviously helping them with a schedule, with reminders, with advocating with their landlords if they have issues. We had a client that had issues with her plumbing and wasn't getting any help. So things like that, and advocating and preventing eviction. So we're going to be working closely with them, or maybe if they need to move because something's going on. Most of our clients are housed through Housing Authority. We would work closely with them as well to provide advocacy and support. And then we talked a little bit about the reminders. A lot of our clients, do need help with finances and stuff like that. So we will help with that. And if there's a circumstance where they may fall behind for something unforeseen, then there is some maybe assistance that we can provide for their payments. The second part of that, which is huge, is our medical support advocacy. A lot of our previously homeless clients have medical issues, but haven't had support with being able to obtain Medicare, or whatever they need. So we are going to be working closely with that. We'll help them with contacting primary care providers, getting referrals, coordinating with their health plans, and getting them durable medical equipment as needed. And then obviously the hardest thing for our clients are to apply for all those programs out there like Medicare, Medi-Cal, cash, whatever it is that they're eligible for. That's the kind of advocacy and support we're going to work with our clients with. So next slide, please. So the other category besides the advocacy is obviously the linkage to services, and some of it we touched on, but more specifically, a lot of educational programs that we're going to link them to and assist them with, because of their history and maybe being transient for a while, we're going to start and helping them with gross, money management, bill payment, helping them with groceries, maybe dietary needs if they have medical issues. So providing a lot of educational and also linking them to outside resources if needed. We have some clients that have issues with hoarding in the past, and we see that when they come into new housing, we see it sometimes starting. So we're going to be working closely with them when we're seeing stuff like that, that we can, you know, start working with them on organizing and home cleanliness and all that stuff that can get them in trouble or at risk of being evicted if they don't keep up with it. So the other part is the behavioral services. We are going to help them if they're not already linked to mental health services and or substance abuse if they need it. And part of that, obviously, the hardest thing is the follow-up. So we'll be working with them and making sure that they are making those calls, that they are doing their medical compliance when they are prescribed medication, and that there's that they're compliant with their case management, because we do see a lot of issues with the lack of follow through or not understanding. So those are some of the linkages and services that we're going to provide, is making sure that they're receiving all of that, and that there's no disruption in their needs. The other part of the linkages is going to be community resources, obviously because of money management and lack of a lot of financial support. We're going to link them and hook them up to food pantries, to transportation if they need it. And transportation could be through their medical plans, which a lot of them provide, or outside services. And then luckily, working with Office on Aging, we have lots of other community resources that we can also link them to. Other things that we're going to help them with is obviously if they need things like refrigerators, mattresses, linens, clothing, etc. So material aid is going to be another huge component of our case management. And then last but not least, for services is caregiving and in-home support services. So if we see that the client is in need of in-home support services, we'll help linking them to applying for services, and then also working with them and public authority to find caregivers. Some of our clients already have IHSS in place and have caregivers, but there's problems with them keeping their caregivers. So we're going to be working with them closely and helping them find and also advocating and working through that. So lots of stuff. This is just a few of the things that we're going to do. It's not all inclusive, but it's kind of what we see is going to be the biggest needs for our population to keep them safe and housed. So that's it for services. Miley, do you want to finish up?
But we do have a question in the chat box.
We do,
from
okay.
Carol,
Okay.
asking who is eligible for the program.
Okay. All right. So the eligibility, obviously, there isn't anything set. We get our referrals from, like Miley said, from adult, from internal, from HelpLink. So any homeless person that needs housing, they've referred to us. We can also provide resources for that. That calls the HelpLink line, or with adult services, the clients that are coming to us, the requirement there is that they need to be housed, and they need to be at risk or need resources for the case management, so that there's stuff that they still need that we can follow up with, like the medical and all that stuff. So so those are pretty much the requirements. For those that come in that are not housed but need referrals for housing, we will work with them. Obviously, we wouldn't do the whole case management part of it because they're not housed yet, but we definitely would help support them with referrals, with outside resources and stuff like that. Hopefully that answers the question. Any other questions so far?
And
I
just wanted to add, sorry, on the material aid, if we go back to that slide, Melanie. So Juana had mentioned, so part of following up and stabilizing our homeless seniors is to make sure that they have, you know, furnishings and things like that to have the comforts of home, but also to meet their basic needs. And so we really partner with our other community agencies to help with some of these items and cover the costs for that. Of course, there is a budget, there are some funding limitations. And so, networking with our partners is really essential to provide some of these appliances and furnishings for our homeless seniors. So it really does feel like a home, and it reinforces, them to really stay on track and follow up with services that they need to really stabilize. So I just wanted to put some emphasis on that. So if any of you can think of some funding resources or agencies that can help us with this, we do have a team of staff who focus on just material aid, and we discuss client needs and look at approvals and do a very thorough research of resources out there for funding to help with this critical need. And so just to put it out there for everyone here, we really want to network with all of you for especially for that particular piece, amongst other things too as well. And I'm sorry, we also have Gary Robbins, who's our deputy director. I'm not sure if he had anything to add, and I'll look in the chat if there's any more questions. Gary?
Yeah, there is.
Yeah, thanks, Miley. Thanks, Juana. Thanks, Tanya, and everybody else. No, only thing I would add is that we're excited about this opportunity. We are excited, in particular, to work with Adult Protective Services, and where APS in particular has sort of been managing a good number of these cases that pose. We understand sort of the need to find a longer term case management solution for folks that need that, and so we're excited to be able to provide these resources, especially to assist APS, but certainly the community at large. So, yeah, we're in the process. Just to sort of be upfront, we're in the process of still recruiting for some of the positions that are related to this program. So we're not 100% ready to open all of the doors quite yet, but we're on the cusp of that. So we'll provide more information back to the COC through Tanya, or as we get further down the path.
Thank you, Gary.
Yeah.
I had a follow-up. I know that I think your department worked closely with DPSS to finalize a homelessness report for Riverside County, and we were able to distribute that report to the continuum of care. Can you share a little bit about that and maybe some of the findings that I think can just speak to like the overall need about why we should be targeting seniors, and what some of the findings were regarding their specific or unique needs in relation to other populations.
Yeah, sure. Good point. So, I think in particular, and there was a COC meeting. Oh man, time is a flat circle these days. So maybe 6 months ago, could have been 8 months ago. I don't know. But Barry Dewing and I came in and just sort of spoke a couple of minutes there. And one of the things that we mentioned there, but are still remain true, really is that homelessness takes a particularly hard toll on folks that are older. The hot and the cold changes that come from living on the streets take a physical toll. You have folks that may be dealing with dementia, Alzheimer's, and other kind of cognitive issues or behavioral health issues that are particular, or often most particular, to older adults, mixed in there with a lot of the very real, of course, challenges of being homeless sort of on top of it all. And so there's definitely, I think, a need. I guess one other piece I would add is we already know, I think that when you look at folks that are in need of some acute medical care, often you already identify, some folks that are experiencing homelessness, but then seniors also have their own acute medical care needs, right? And so A lot of times, a shelter, for example, may not be equipped for an oxygen tank, or equipped for the kind of bed that someone might need, for example, to really be able to thrive and kind of get back on their feet. And so some of those challenges, just in terms of being an older adult and then being homeless and not having all the access to all of those resources, or I guess not the appropriate resources to meet exactly what your needs are, definitely come into play. And so I think one of the things that was found and what had been highlighted previously is rates of death for homeless seniors tend to far outpace not only regular homeless adults, but seniors as well, senior population. And so you have earlier death, you have death that happens more quickly than it would if proper care was provided. So I think those were definitely some of the kind of findings and some of the things that, in collaborating with APS, we've been, I think, trying to highlight and trying to sort of bring a focus to these particular needs of homeless older adults.
Great, thank you, Gary. As you were speaking, there were a couple questions that were added to the chat box. Question from Karen Roper: is the Office on Aging call center an ADRC? I have to apologize, I do not know what that acronym stands for both seniors and those who are disabled. I know the age groups vary among disabled versus seniors depending upon program, vary from 55 to 60 or 65 to 65 years old as thresholds.
Yeah, so that's a really good question. So an ADRC is a designation that the state of California has implemented, and it's been in place for actually quite a while, a number of years. It stands for Aging and Disability Resource Connection. And Riverside County is fortunate enough to be one of 6 designated ADRCs, sort of somewhat unique among offices on aging or area agencies on aging. And then the other counties around the state are sort of a program to be an emerging ADRC. So anyway, long story short, Riverside County Office on Aging is an ADRC, and part of what's required to be an ADRC is we have to be partnered with the local independent living center, and so who work with disabled adults. So they provide accessibility, they consult on a lot of they sort of provide, have a number of services that they can provide to adults with disabilities. We do too. Some of our programs certainly, have different age thresholds. But if it's not a program that we directly have in-house, we work very closely with Community Access Center, which is the Riverside County's independent living center, to serve the needs, to work together to serve the needs of those. So when you do call HelpLink, when you do call the call center, you are calling the Riverside County's ADRC, and you sort of we would then kind of work together with ILC to be able to provide, assess and provide services.
All right, thank you so much. And Karen Roper just gave you kudos. Nice job on the ADRC response.
Thanks, Karen. That's a good question.
There was another question. So I know this is a new program that you guys are going to be implementing. There was a question in the chat box from Juana Gonzalez. My apologies. I'm sure I didn't say that correctly. But in regards to, are you partnering with Home Connect? So Home Connect is a 24-hour hotline being managed by our coordinated entry system lead, County Behavioral Health Department. And it's essentially like the 211, where anyone who is experiencing homelessness or at risk of homelessness can call to get connected to services. So
we're happy to collaborate. And now that we've met in this arena, definitely we put in some of our contact information. maybe we can set up a time on the side to meet and talk about how we can collaborate and join our efforts. Definitely. So, and anyone's free to reach out to Juana and I, and of course, any of you who have Gary's contact information are welcome to go through him as well, and we can set up some time to connect with Home Connect to collaborate.
Love it. And I think what I'm taking away from your presentation is that, again, new program, but by all means, you guys are eager and ready to partner with any stakeholder who shares your mission and is targeting whether it's disabled adults or seniors. So thank you so much. You guys did an excellent job. And again, this video will forever go down in history. It's going to be posted on our website. I know that it will be such a great, the information you shared will be such a great tool, especially for all of our supervisors and frontline staff who are working day to day to connect people to services. So thank you for joining us.
Hey, Tanya, it's Karen. Can I ask a question?
Yeah, please do.
So this is Karen Roper, and this question is with my City of Corona hat on. I know that sometimes Office on Aging staff will work with community partners and outstation staff in different subregions of the county to try to reach a target population. And I just wanted to put it out there for potential future discussions with the Office on Aging. We are building a shelter and navigation center. I've been putting plugs out there a lot to the community, but our goal is to have multidisciplinary services at the navigation center. And we will have all kinds of services ranging from medical to mental health, dental, life skills, and the senior population is really important to us, and we do have homeless seniors in our region of the county. Would love to have a follow-up conversation with the Office on Aging about any potential partnerships for some on-site services.
Yeah, that's
Exciting.
fantastic.
Yeah,
thank you.
sounds
Yeah.
great. Reach out to us, Karen. Thank you.
Yeah, for sure, I will. Thank you. Sorry, Tanya, I didn't mean to jump in.
No need to apologize. Those are exactly the types of connections that we are hoping to facilitate through these webinars. So thank you. You can see Melanie smiling real big. This is what we want to happen. All right. Thank you again, Office on Aging, Gary and team. Great presentation. We will now jump over to hear from Rosalie Ramirez with In-Home Supportive Services. Office on Aging referenced their program quite a bit in their presentation. So I think this is going to be a very easy transition to their presentation. So Rosalie, thank you for joining us. We are ready to hear from you.
Okay, good morning, everyone. I'm Rosalie, Program Specialist. I've been with the county 10 years. 4 years were spent in the desert area, another 3 years in the call center for Adult Protective Service and Home Supportive Services, and now policy, IHSS policy. So let's get right to it. Next slide. Okay, so today we're going to focus on IHSS, what is it and what it's not, how to make a referral, what are the benefits of having a caregiver, a provider, and how to become a caregiver, and also how to tackle the Medi-Cal share of costs, and any questions you might have, we can answer them at the end. Next slide. So objectives of DPSS and IHSS, we want you to be able to recognize our program and differentiate from other programs out there. We want you to gain awareness on the application, assessment, determination, and notification processes, as well as the public authority. And we also want you to learn how to make this program work for you guys. Next slide. Our purpose here at DPSS and IHSS is to empower vulnerable people in the community. And one of the ways we do that is with IHSS. So the goal is to get people to stay in their homes as long as they can and avoid out-of-home care, because it costs the state 4 times as much to institutionalize someone than to leave them in the least restrictive environment in their home. And in our county, IHSS is administered by Adult Services Division. Next slide. So what is IHSS? So basically, IHSS follows the same rules as Social Security and Medicaid. It is, the eligibility is determined by social services practitioners, and we are funded by federal, state, and county dollars. So we all know that when there's money attached to a program, there's rules that have to be followed. So there are 4 different funding sources or pots of money. So one of them is our 2N program, which is mainly state and county monies, no federal monies, and that's a very small population of our program. There's also the Personal Care Services program, which is funded by all 3 sources of money, and that's over half of our people. And there's also the IPO program, which is a smaller population, but that's usually when it's a parent provider or a spouse provider. This is very important because when you have a parent or a spouse, due to the family code, and you have legal obligations to provide certain services to your family. So these cases are a little bit more challenging sometimes, but they are there. So that is a service out there for parents and children. And then there's also CISCO, Community First Choice, I believe. And those are our clients that have a higher level of care, a nursing level of care, and that's 43% of our clients. Next slide. So our eligibility criteria, I just want to have a disclaimer now. I have a lot of slides because I'd rather give you all the information up front. So I'm going to go through some of these rather quickly. And so if you have questions later on, let me know. But again, our eligibility criteria, you have to be 65 and older, blind, or disabled. So we do have 9% of our caseloads that are children. So children also qualify. It doesn't have to just be seniors. So they also usually come from a low-income household. But the only exception to that, you can sometimes be up to 250% of the federal poverty guidelines and still qualify. And the other big exception would be our extreme cases, our 6V cases, which are usually inland regional clients. So those are our like extreme, severely disabled population. So sometimes income doesn't matter for that population because they're institutionally deemed. So we don't consider family income at that point. Also, they have to reside in the US or be California residents, or they could be PUCO, which is a person residing under color of law. But that doesn't usually happen very often. And that just means that immigration knows you're here, but they're not taking any action to remove you from the country. Also, you have to live in the community. You cannot be in a facility. You cannot be in a skilled nursing, a board and care, a long-term care facility. So you have to be in your own home. And your own home can be defined as sometimes a hotel room, a project room key, sometimes an RV. It just really depends, because I know that's an issue with your population. Also, you need to have a medical certification from a doctor. It has to be signed by a physician. It can't be any of our staff. It can't really be a nurse. It has to be someone licensed by the state to practice, healthcare in the state. You also have to have a functional impairment that lasts beyond 12 months or ends in death. Next slide. So there are other programs in the community. For example, one very similar to us, and we even use the same system, CMIPS, is WPCS. We do enroll those providers, but that is not our program. But the state uses our system and our staff sometimes to onboard those caregivers. But that's a totally separate program. In-home operations is another state program, and that's basically when your living room or your room gets turned into like a mini hospital, where you have like all these machines and you have private duty nurses. that's in-home operations. The Veterans Administration has the Aid and Attendance Program, where the veteran pays someone, like a girlfriend or spouse or a friend, neighbor, to take care of them. So that's not our program. And then also there's a regional center or school districts that provide one-on-one aids. So these are all different resources, but they're not IHSS. But sometimes they get confused with IHSS. So just be mindful of that. There's also SCAN. There are 6 different types of health plans that SCAN provides. And some of these health plans restrict you from IHSS because it's double dipping for Medi-Cal. So if you do have SCAN, you know, sometimes you're going to have to choose. You can't have both. And also PACE, if you have PACE program, that's more popular in San Bernardino County. It's not as popular here in Riverside. That will disqualify you from IHSS. Next slide. So a lot of our clients, IHSS is Medi-Cal paid. So Medi-Cal is a state program and Medicare is a federal program. So a lot of our seniors over 65 have Medicare, or people under 65 who are on dialysis, have really bad disabilities, you know, dialysis, diabetes, congestive heart failure, stuff that's very, very serious. So those are the people that get qualified for Medicare. Medi-Cal is what pays for IHSS. So there's a difference between the two. A lot of our clients have both. Some of them just have Medi-Cal. So just so that you're able to differentiate, Medi-Cal is the blue card, the blue and white card. Medicare is the red and blue card. Next slide. So we have 9 regional offices. Right now, we're not taking appointments, walk-ins, sorry, we need appointments due to COVID. Our staff are not at the offices usually because they're working from home. So this is why you need to call us and make an appointment if you have any like paperwork you need to turn in or anything like that. So those are our addresses, our locations, and our hotline, the home hotline. Next slide. So there's a short little video here I wanted to show you. I don't know if you can click on the link, the top link, not the bottom one. The bottom one's too long. You might want to watch that later on at home by yourself. But the top link, it's a 2-minute video about what caregivers do. So I'm not sure if you're able to play that.
Yeah, I'll have to share that screen. Let me change the view.
It's really brief. It'll give you a better idea of what our caregivers do every day for our clients.
Riverside County is now hiring compassionate and committed caregivers who want to make a positive difference, helping seniors and dependent adults with their daily activities.
It allows me to have an independent life. I would literally be in an institution without someone helping me at home.
Caregivers help Christine Loomis live safely at home. They're hired, trained, and paid for by Riverside County In-Home Supportive Services, or IHSS.
There's a feeling that I could actually have some control over my life. Not only survive, but have control over my life. And that's amazing.
IHSS helps 38,000 Riverside County adults remain safely in their home. More caregivers are needed to keep pace with a growing aging population. Caregivers earn $13.25 an hour with a flexible work schedule and benefits. Training is free. Is this a job for you?
Someone that has a good heart. Someone that's a kind person.
Like caregiver Gabriela Suarez, who does household chores and helps Christine with personal care and working from home.
It's non-stressful, very relaxed. You feel like you're home.
More than just a job, making a difference.
Being her provider is my home.
If you'd like to apply, call 888-960-4477 or visit riversideihss.org.
Okay, next slide. So there's 4 ways to apply. You can apply online. You can apply over the phone, paper application. If you go online and Google SOC 295, that's our IHSS application, the paper application. You can drop it off at any of our locations or mail it. You can also send us a fax. Our fax number is 951-358-3969. So once we receive your application, you will get a 7-digit case number as a confirmation that you applied, and you will be mailed a medical certification. And that has to be turned into us within 45 days. Right now it's 90 days due to COVID because of all the challenges people are having, but typically it's 45 days, and that's a state mandate. Next slide. So the minimum amount application information we need is name, date of birth, address, and social. If you do not have a social, an ITIN is okay, or a pseudo. Pseudo numbers are usually our adoptions clients, you know, children who we don't have their social or they're being protected from someone being able to find them in the system and things like that. So if you know the pseudo number, that's a lot better for us, because sometimes it's a little tricky to make sure we have the right case for the right client, especially when there's multiple records and things like that. Next slide. So any other information you have that helps us with application is what exactly do they need help with, who lives with them, do they have a network of support system, do they speak English, Spanish, any other language, do they have an emergency contact? Because a lot of times we call our clients, and because they change their phone number so much, it's hard to get a hold of them. So sometimes our applications are denied because they don't answer our phone calls. Also ethnicity, income. Income's really important because we have to verify everything with Medi-Cal, make sure that everything is correct. And also if they have any other health coverage that helps us with our determinations. Next slide. So our application process, again, we forward to Medi-Cal. The social workers usually get out to the home within 30 to 45 days. Sometimes it can take 90 days. You know, optimal is 45 days. And if we do not find you after 3 attempts, if you do not answer our phone call, if you don't, you know, you're not ready for your video call, we mail you a letter with your appointment date, all that. 3 attempts, we try to contact you, you don't answer, we will deny your application because there's no response. And sometimes some of our clients move and you know, the address isn't updated. So that's very much an issue with the homeless population. Also, if you don't hear anything from us within 45 days, call the hotline and ask what your status is. Next slide. So we are able to authorize services based on the social worker's observation, what limitations the client has, what are they safely able to do. You know, we don't want people falling down in their home because, you know, they're not ambulating properly or they're tripping over rugs. So what are you safely able to do? That's what we want to know. And also we need to see that medical certification signed by a doctor. Next slide. So this is the medical certification. You basically have to turn this in within 45 days. At the bottom of the application, the doctor signs. He certifies that you need help and also puts his licensing authority number. So the 3 key questions on this form are right next to the red marks. So basically number 1 has to be answered yes, number 2 has to be answered yes, and number 4 has to be answered yes. If any of those questions are not marked yes, that's going to be that's probably not going to get approved. It's going to be a very hard case to prove that you need help. So next slide. The notice of action. We're mandated to give you all of our notices in writing. If you do not get a notice from writing in the county, something's wrong there. So if you're approved, we will send you how many hours you're approved for. It can range from 0 hours to 283 hours. 283 is the cap. So this is not a 24-hour job. This is like maybe at most a 9-hour-a-day job for the caregiver. So if you are denied, we will tell you why you are denied. And if you do not agree with us, you can always take us to a hearing. Next slide. And all that information is on the back side of the NOAA. So we have about 37,000, almost 38,000 clients. Like I said, 9% are children, 15% are like younger adults, 23% are 45 to 64, and over half are 65 and over. And a lot of those clients have paramedical needs, some of them. There's also protective supervision, which those are usually the clients that get the maximum 283 hours. And these are probably like 4,000 individuals, 5,000 individuals in the county. And these are cases where, you know, they can place themselves in danger, they have no self-awareness, they're nonverbal sometimes, and, you know, they have harmful behaviors towards themselves. Next slide. So there are Federal Labor Standards Act overtime rules. Before that wasn't the case, but the union, you know, and the caregivers organized, so they were able to get these FLSA rules applied to them. So the maximum a caregiver can work is for one client is 70 hours, 70-45. And if you have more than one client, the caregiver can work 66 hours. And the very rare case that no one else is able to provide for a certain client, no one else, you know, it's very challenging to get a caregiver for them. And that's a very small population of our clients. They can work up to 90 hours, but that requires an exemption from us and the state. It has to be evaluated by us. So that does happen, but there are people who can work up to 90 hours. And the wage rate, next slide. The wage rate, I believe, is $14.50 right now. The video said $13.25 because that was last year, but I believe by next year it will be $15 an hour. So really simply put, the program is, say grandma or grandpa gets approved for 100 hours, a daughter, niece, neighbor, whoever can provide care for that person at $14.50 an hour, they're going to make $1,450 gross. So that's basically how the program works. And wage rates differ depending on county. Next slide. So that's why that tax relationship is really important when you're filling out the forms. Next slide. So the IRS did rule that IHSS income is not part of income. So like say you're applying for Medi-Cal and you're afraid this is going to affect your Medi-Cal benefits. It's going to be counted as income. So depending on that relationship, that's really what matters. Also, some people are like, oh, it's going to affect my housing voucher. So just talk to your workers about this, but it's not really considered income if you're like a parent, spouse, or you live in the same home. Next slide. So our system interfaces with all these other state systems. Some people, sometimes there's issues with garnished wages, things like that, fraud. So our system does talk to other systems, so just so that you're aware of that. So if you do tell us, you know, something and it's not accurate, we're eventually going to find out. Next slide. So these are the type of services: cooking, cleaning, shopping, errands, personal care, protective supervision, paramedical. Next slide. we can authorize those services for someone to be paid. We cannot authorize babysitting. We cannot authorize accompaniment to social gatherings. We cannot authorize caring for your animals, caring for your gardening, paying your bills. Like, that's not what our program is for, because there's a lot of liabilities with that and potential for, financial abuse and things like that. Next slide. So our social workers go to the assessment and all that. We talked about that. Next slide. And they look at, the regulations clearly state, we have to look at all these things, and that's how we make our determination. Your physical and mental condition as well. Because even though someone doesn't look disabled, that doesn't mean, they don't have a disability. Next slide. So we rank everyone from 1 to 5. 1 means you're independent. 5 means you need total care, total help. Someone who's bedbound, wheelchair bound, things like that. And number 6 would be a paramedical need, where you're inserting an orifice of the skin, or inserting something, or puncturing the skin, or like wound care, ostomy bag, colostomy bags, stuff like that. Next slide. So our program is a voluntary program. We cannot force it upon anybody. A lot of times there's families that want their parents to be on the program, and sometimes their parents refuse because they're like, I don't want anyone to get paid to take care of me, because then sometimes there's disagreements within the family. We have to respect our clients' wishes to self-determination unless a court determines they lack capacity. So we cannot force anyone to participate in our services. Next. So there are status eligible cases. These are people who get automatic Medi-Cal. I'm not sure what the going rate right now is for Social Security, but I think it's somewhere around $1,000 a month. So those are the magic numbers. Write those down. So if you're an individual, it's usually under $1,200. If you're married, you want to be, closer to the lower end of those numbers. And you can't have more than 1 house or 1 car to be on Medi-Cal, and you can't have more than $2,000 or $3,000 in the bank in savings. Next slide. Income eligibles, these are a little harder to determine, but that goes all through Medi-Cal. If you have a sure cost, if you're past that $1,200 mark and you have a sure cost that says like $600 a month, there might be ways around that. So there's a working disabled program that allows you to be higher up in the thresholds, in the income thresholds. Next slide. So this is what our Medi-Cal workers use. These are the magic numbers, the different percentages of the poverty level. So usually the sweet spot is like 120%. Anything below that is usually free Medi-Cal for the most part. And then next slide. Anything above 250%, you're usually probably not going to get free or reduced Medi-Cal. And it's pretty expensive to age in our country. So we have our Medicare premium payment, where that little red star is, Part A and Part B. So usually this is taken out of your Social Security check when you're older. And also if you are married, there are special rules when you're married. So we can treat cases a little differently sometimes and get one person placed in long-term care, and another one, would be denied Medi-Cal. Next slide. So this is the Working Disabled program. There's a flyer attached to the presentation. Melanie will make sure you get that. So that just has questions and answers of how to work with the Working Disabled program for Medi-Cal. Next slide. So independent caregivers, if you're looking to be a caregiver or know someone, usually they have to pay for their fingerprints. They're $40 to $90. They complete all the forms, and they complete an online orientation. And it just basically explains fraud to them and the rules of the program. And also, our caregivers cannot claim time while a client is in a hospital or facility for more than 2 days, because that could be fraud for us. And we do get reports from Medi-Cal when a client is admitted to a facility. Next slide. So the providers can be anyone, can be a family, friend, neighbor, A very small a small part of our population is has no network, no support network, no family. Maybe all their family, is deceased, or they just never had children. So that's about 10 to 20% of our clients, and they need the most help finding someone. So the recipient is the employer, and they hire and fire and train whoever they seem fit for the job. Next.
Rosalie, we are at time. Do you want to take about 2 minutes to kind of summarize your presentation?
Yeah,
the
sure.
remaining pieces there? Perfect. Thank you.
Okay. So people with records can work for us. They just have to go through an exemption process. So if you have a record, it depends on the charges. And also, that's pretty much it. The client hires and fires and trains the caregiver, and we just do all the paperwork and the payroll part, basically. So you can't have child abuse, elder abuse, or welfare fraud. So those are the only charges you cannot have and work for IHSS. Next slide. So those are the type of crimes that disqualify people. Next slide. So just the word on fraud, it is investigated by our investigators, so just don't do it. Next. And that is the Fraud Hotline. Next slide. This is my contact information. If you have any questions about Medi-Cal, Medicare, Molina, IEHP, anything that has to do with IHSS, give me a call or email me. I'm here as a resource for everyone.
Thank you, Rosalie, for that presentation. Lots of information. Thankfully, again, it's recorded, and for everyone in attendance, this recording and any attachments, the PowerPoint presentation, will be posted on our website. Melanie did include a link in the chat box. We just want to say one last thank you for joining us. When I looked at us at our highest level, we had about 45 people in attendance, which again just shows that these things are getting more and more popular with time, and that's thanks to all of our speakers and of course those of you in attendance. So thank you for joining us. I do want to also give a last shout out to Melanie Wilson, who is part of our COC's planning team. Melanie dedicates a lot of time working with the speakers and all of you to make these happen. So thank you, Melanie. We appreciate you. And to everyone else, stay safe. We know you're working hard, and working hard sometimes can get tiring, but know that your investment and time is worth it, and you are, by the nature of your work, saving lives and helping us end homelessness. So thank you. Take care. Blessings to you all. Bye-bye.
Thank you. And our next webinar is on non-congregate shelters on April 22nd at 10 o'clock.